I will start us off, and then Betsy, my co-moderator, is going to introduce our speakers. So I'm Stephanie Wheeler, and I am the PI of the Coordinating Center for the Cancer Prevention and Control Research Network, which is a large multi-center network that is funded by the CDC and supported by NCI. And we've been working together for the past almost 20 years to reduce the burden of cancer and to focus on reduction of cancer disparities in communities with a focus on implementation science. So here is a map showing where our centers are located. You can see we've got great geographic diversity and lots of really wonderful investigators represented. We also have practitioners that are part of the network as well as scholars. And we are the oldest thematic research network that is funded by the CDC. And you can see our vision and mission statement here. And for those of you who aren't familiar, if you'd like to know more about CPCRN, take a look on our website, www.cpcrn.org, and we would love to have you join us. Next slide, please. And I'm going to be introducing Betsy Risendal, who's one of our PIs. Betsy has been part of the network for quite a long time and is really a wonderful expert in cancer prevention and control, and she is based in Colorado. Betsy, want to take it from here?
Thanks, Stephanie, and I would like to welcome today our panelists. First up, we have Dr. Cam Escoffery, who's a professor in the Department of Behavioral Health and Behavioral Sciences and Health Education at the Rollins School of Public Health at Emory University and is PI of the CPCRN Center at Emory. Next, we will have Dr. James Hébert, Health Sciences Distinguished Professor in the Department of Epidemiology and Biostatistics at the Arnold School of Public Health at the University of South Carolina. Dr. Hébert is co-PI of the South Carolina CPCRN Center. Next, we will have Dr. Cyndi Thomson, Professor, Department of Health Promotion Sciences at the College of Public Health, University of Arizona. She is PI of the Arizona CPCRN Center. And then we will finish with Dr. Jackie Shannon, Professor, Epidemiology, Health Promotion, and Community Health Programs at the Oregon Health and Science University at Portland State University School of Public Health and CPCRN affiliate member. And again, welcome to all of our panelists. We're excited to hear about your experiences using mini grants in your communities. I know we have a lot of slides and great information to get through today, so let's go ahead and get started with our first speaker, Dr. Escoffery. Thank you.
Thank you so much, Betsy. It's a pleasure to kind of share some of our work from the Emory Cancer Prevention and Control Research Center. So I'm presenting some of our work on behalf of myself and Courtney, who is my project coordinator. Next slide. So just to give you the focus of our mini grants program here at Emory, we are focusing on HPV vaccination. These are just some data that highlight the need to focus on vaccine rates in Georgia. We are still below the wanting to be closer to 80% plus vaccination. So here in Georgia, we have about 54% girls who are fully vaccinated and 1% of boys. We also noticed that the last point here is that in our rural areas across the country, that vaccination rates for HPV to prevent cervical, oral, and other types of cancers are much lower in rural areas than urban areas. And that's true too in Georgia. Next slide. So our focus of our Emory specific project, I just highlighted the two aims, is to kind of have a mini grants program that will focus on multi-level interventions to different clinical or organizations that provide HPV screening to try to make a difference in HPV vaccination rates. And 2B is that we're going to be able to evaluate through implementation research some of the different strategies that they use. Next slide. So this is our structure that we want our mini grantees to be able to offer the vaccination. So number 2 could be some of the different organizations we might be working with. Of course, health departments, clinical systems, our individual clinics, or of course, university health centers, so probably colleges. And then the type of mini grant we're offering is having mini grants of around 6 different centers or organization and 2 cohorts, as you see here. And we're thinking around $3,000 within those cycles. Next slide. So here is a little bit of what we're going to do once they get funded. They're going to receive training and technical assistance, and we're going to just have a small pragmatic evaluation trial. So we're going to ask them to choose between one of these 3 levels to work with, and then choose another level. So they could work at the individual and provider level or individual and practice level. And they'll get some information about how to do these things. And these are all recommended strategies, either from the community guide and or evidence-based interventions. And at the end of the 1 year, we would like to be able to look at the initiation and completion rates of HPV vaccination. And again, depending on their age, it will be the 2 to 3 doses. Next slide. So you guys are somewhat interested in how we're doing this. We are planning to do this next year. So we're just starting to kind of get the application phase together. And so it's a community-based grant form, only 3 to 4 pages. We ask for background on the organization, importance of HPV vaccination in their community, and the current rate of vaccination, whether it's initiation or completion, and their ideas for the interventions, looking at some of the 3 levels that we talked about. The way we foresee doing the application review is we have our community advisory board that is in conjunction with our Prevention Research Center. We have a small HPV advisory group, and they will have a grant review form that we have used before in our formal mini grants. And these are some of the areas that we grade them on: demonstrated need, detailed plan, where is the organization in terms of their work on cancer screening, vaccination, and their budget and what they need. And we typically have individual round scoring and then a full discussion with our committee. Next slide. We're kind of building our mini grants for this HPV vaccination round based on some of our past work, where we have funded community organizations, typically community-based organizations like churches and social services organization and public health organizations, to adopt cancer evidence-based practice, either from the community guide or from the evidence-based cancer control program, formerly known as RTIPS. And so these kind of give you some of our different mini grants programs that we have done. And next slide. I'll be around at the very end to answer questions. We may not be able to give big checks in person this next year, depending on how COVID plays out, but this is a picture of our community advisory board who will be on some of the reviews, and then a picture of our mini grants. So thank you very much.
Thank you, Dr. Escoffery. That's great information. And as Stephanie noted, please feel free to put questions in the chat, but at this time, we're going to go ahead and move to our next speaker, Dr. James Hébert from South Carolina. Thank you.
Okay, so this is actually a condensation of what Sam and I presented at earlier in the summer. So some of you have seen some of these slides, well, at least versions of these slides. I've modified them somewhat for the purposes of this. So this is a picture from one of the events that was done by one of our community partners who was a recipient in the former round. Next slide, please. So our CHIP mini grants program serves a number of functions. First of all, it connects us with the community. and it connects the community with us. So it keeps us engaged, which is great. It provides extra research and program familiarity. So it's a really efficient use of resources. In that sense, it gets us out there in a way that's way more efficient than if we tried to do it directly with university resources. We make grants in years 2 and 4 of the funding cycle. So we've already made a couple of grants in this funding cycle. The awards are up to around $10,000 or up to $10,000, and they have been right around $10,000. Grantees in the current round we're told to focus primarily on rural communities. And our de facto foci has been on screening, diet, and physical activity. Those are the things that we have focused on as a CPCRN, and our partners are aware of that and also have used that as a foci for their interest as well. The grantees partner with a federally qualified health center or rural health clinic or some other clinical setting. We provide multimodal technical assistance that's tailored to each of the grantees. And the amount of assistance varies according to need, so it can vary quite a bit. Previous CHIP grantees serve as advisors to the program. So we engage them and they stay engaged. And liaisons to the grantees, we provide liaisons in the CPCRN to the councils and to the grantees. Next slide, please. So this just depicts that we're using evidence-based interventions. These are packaged programs that tend to get modified according to the needs of the community. They can focus on policies, and then we also have a strong strategic orientation. And our focus is really on both environment and behavior. So you'll see in the couple of the grantees that we have where we focused on the environment in which people engage in certain behaviors, for example, physical activity. Next slide, please. And we use the IM ADAPT 6 steps procedure here, and we go from 1 to 6. So we do everything from conducting a needs assessment, assessing organizational capacity, helping folks pick an evidence-based intervention from the list, providing pre-award assistance to post-award technical assistance. So it's pretty comprehensive, and our awardees really appreciate that. Next slide, please. So a little bit about our procedures. So we call for applications through our network channels. So over the 20 years or so we've been doing this, we have a lot of network channels. Plus we do other things besides CPCRN work. So we have a lot of connections and we can get the word out pretty effectively. We hold a webinar 1 month after the RFA is sent out, so people know the RFA is coming out. They're tuned into that. We arrange for the webinar, people attend, they get this additional information, and then they begin writing their application. Well, some of them begin even before that. We provide continuous technical assistance through our project coordinator, that's Sam Noblet, who's on this meeting right now. Applications are sent to team members. So these are CPCRN team members who have area expertise that matches with the applicants. And then a little bit about how we evaluate the applications. These are also, like Emory's, relatively short. I think they're 5 pages, and they're evaluated on each of these questions or criteria. So the first one is organizational structure and staff experience. The proposed proposed program is the next one. Experience with the target population and program compatibility. Plan for assessing challenges and barriers, staffing and program champion, an evaluation plan, budget and budget justification, including timeline, because they got to get this done in a year, basically. And it was truncated this year because of COVID-19, unfortunately. And then finally, technical quality. So that adds up to 100 points. And we evaluate it just like we do in an IH grant. On these criteria, giving the points, and we let the the applicants know, and we give them feedback whether or not they were funded. So next slide, please. So our current recipients are Trinity Baptist Church, and they're helping people get up to date with health screenings. And I know when we had our meeting last week of the survivorship work group, this came up as an issue that, COVID-19's really thrown a monkey wrench into the works. On the one hand, it's created a lot more demand in medical delivery systems and public health delivery systems. And on the other hand, it's done the opposite. And one of the things that's fallen by the wayside is the things like cancer screening and so forth. So Trinity Baptist Church is focusing on that. The other of our recipients was the Upper Midlands Rural Health Network. Midlands is the center of South Carolina. So where I am in Columbia is considered the Midlands. And they're a little bit north of here. They're in a county called Fairfield. Well, they're in 3 counties. The focus of the walking trails is Fairfield County, which is probably around the same size as Richland County. It's 700 or so square miles, but only has 20,000 people. So it's very rural. And my wife and I actually walked on one of these trails over the weekend, and it was bloody brilliant. It was so good. And then I don't know if that link is functioning here, but you can look at their press release if it is. If not, we can make that available to you. Next slide, please. And this is just a picture of the various actors at the 2 recipient organizations. And I think we have one more slide. And I'm here, and Sam's here as well to answer questions as they arise later on.
Thank you, Dr. Hébert, for that rich information. I know it's stimulating a lot of questions for me. Both presentations so far. If you have questions, please be sure and put them in the chat. Stephanie's gathering them, and we'll get to them first thing after we finish with our 4 presenters today. And next up, we have Dr. Cyndi Thomson from the University of Arizona. Thank you, Cyndi.
Hi, Betsy. Thanks, everyone. So today what I wanted to do is present what we're doing in Arizona with our pilot research grant. And what we've decided is really to leverage the resources to support cancer-free communities by partnering with our community outreach and engagement group. And I want to thank them for sharing some slides that I'll share with you today. Next slide. So what we did was we decided that the COE was launching their very first community academic partnership grants. And these grants are actually 2-year grant cycle, and they're quite substantial. They're $150,000. And they really have put a lot of effort into considering the mission and guiding principles. And these mission and guiding principles, as well as the eligibility, et cetera, really aligned well with CPCRN in Arizona. And so we felt like this was the group to partner with to move something forward that would allow us to spend less time on the administrative side of things and get our hands dirty and work with the partners sooner. One of the things I'll tell you right from the start, because I meant to put in a slide early, was our focus is colorectal cancer screening. In Arizona, in our catchment area, about 40 to 68% of people eligible to be screened for colorectal cancer are actually being screened. The rates are particularly low in our Hispanic communities, and it is a major cause of cancer mortality in our Hispanic community. In addition, as most of you already know, the age of screening has dropped to 45 years. And so there's a need to make sure that people are aware of this. So we are working with the Fit Food program. The next slide. Eligibility. So when the CAP grants were initiated, eligibility was set with nonprofit organizations, including tribal entities, and you can see the other criteria here. But the priority is really for Southern Arizona and the border communities where we work and play as a CPCRN as well. Next slide. So there is a letter of intent, and this has been extremely helpful to help people understand the capacity of the grant, what we're trying to accomplish, and to make sure that in partnering communities and academic individuals that they have a shared belief in where they want to go with the grant project. So that was particularly helpful in guiding people. Next page, next slide. They do develop a full proposal with budget justification. They do include biosketches for both the community partner lead and the academic lead. And they can get letters of support and letters of collaboration that also support the process. And it's 5 pages, as others have mentioned. Next. The project timeline that was in place was October of last year, when COVID was in its prime in Arizona. But we were able to go through the LOI review, the notifications, the applications were due in November. We did the review of the applications, and then the notice of award was given in January of 2021. And about 2 to 3 weeks later, the CPCRN project was also selected. We right now have 1 mini grant funded, and we've given them $5,000. The reason this says 5 to 20 is because we have some matching funds that we've been able to identify, and we're working to spread from one FQHC to additional FQHCs with the Fit Flu program. Next slide. The application has a robust evaluation process. We have people who, in the actual application, they have to give us a lot of information about outcome measures and how they're going to collect data, how they're going to disseminate their findings. But in addition, in the blue box describes some of our process. We match all applications to faculty members with expertise in the area, as well as a member of our COE Community Advisory Board. And then these applications are scored independently. The 2 groups meet and kind of go through the pros and cons. And I found this to be extremely enriching to see where the Community Advisory Board came down on priorities versus an academician. So it was very informative and helpful. From there, we set priorities. The primary grant was selected, and that one is actually cancer survivor, cancer caregiver project that's going on in the border community. And then from the kind of second runner-up, third runner-up, we had discussions at the leadership level to determine which one could be kind of downsized and still have an impact in the community. And we reached out to those community partners who did not get funding and selected a lead program to move forward with our pilot grant. Next slide. So we had 11 applications total received. As I mentioned, the Cancer Survivors and Caregivers D&I symptom management was the one funded. We are working in partnership with the FQHCs and the American Cancer Society Arizona chapter to launch the Fit Flu project this fall. We also are looking at connecting this with the Fit COVID vaccine booster, perhaps, as another opportunity. Other grants, just to let you know, that were received dealt with things like healthy grocery shopping and food insecurity, lung cancer screening, BAGIT, cancer survivor research dissemination that was geared towards the American Indian population, and then transgender cervical cancer screening, to give you an idea of the variety of grants that we received. And that's it. Thank you. When you come to ASPO next spring, come visit us in the mountains.
Thank you so much, Dr. Thomson. This is great to see our panelists presenting information who are at various stages and have various backgrounds and experiences in this. So thank you again for sharing. We'll go ahead and move on to our last speaker. In the meantime, please continue to put any questions in the chat, and we'll do those at the end. Welcome to Dr. Jackie Shannon from Oregon Health and Science University. Thank you.
Great. Thanks, Betsy, and thanks for all the other presentations. I really enjoyed those. As an alumni of the CPCRN program, it's fun to come back and present with you all. So I'm going to be presenting the Community Partnership Program on behalf of myself and Carrie Winterstone, who co-leads this program, as well as a host of staff that have been helping us implement it. Next slide, please. So the Community Partnership Program, we began in 2015, and our mission is to work hand in hand with Oregon communities as allies in the night's cancer efforts to end cancer as we know it. We do this through 3 specific missions. First, to support Oregon communities in both understanding and addressing their most pressing cancer-related needs. So this was really a priority to us, that we not be telling them where to do their work, but to listen to the community's needs as they come to us. The program aims to enhance collaboration between communities across Oregon and OHSU, and then also to finally provide training and technical assistance to our applicants and our grantees in an effort to foster the skills and abilities of communities to enhance long-term sustainability of programs for addressing their identified needs. Next slide, please. So over the past 12 grant cycles, we have 2 cycles per year. The Community Partnership Program has funded 152 projects, and we've reached all 36 Oregon counties with these projects. The map I'm showing you here shows the number of grants or projects that were proposed and their proposed reach by county. So the one thing that this map shows is that this is the proposed impact. So it wasn't necessarily where the funded organization is actually located, or whether the project was successful in their entire reach. But a number of these projects are located in these outlying counties, and then they reach to within those counties. The majority of our projects indicated that they have at least a partial or a complete focus on rural areas. And from the project's evaluation data that we collect through their annual or final report that each applicant provides, we've reached more than 51,000 Oregonians through these different projects, and 469 partnerships have either been newly developed or have been supported through CPP funding. Next slide, please. So this slide just breaks down by where on the cancer continuum different grants are being funded by our tier of grants. And I'll talk a little bit later about what those different tiers mean. But you can see that the most commonly funded grants have a prevention focus. So this isn't really surprising based on these are community organizations. A lot of them have a focus in these prevention areas. But we do then have a number that focus towards survivorship, and then some that are looking at screening and early detection as well. And then you can note that some applicants can select more than one cancer continuum focus. And so this is why our percentages don't actually equal up to 100. Next slide, please. So the Community Partnership Program funds 3 different types of grants. The tier model is what we've historically funded since the program began, where there's 3 different types of tiers that are available to applicants to address any of the community identified cancer-related need. And I'll describe those a little bit more in just a second. The second area approach that we've used for funding is called the Community Action Model. And these grants are intended to focus around a pre-identified priority cancer topic. It's a 5-step model, and I'll talk about that here in a minute as well. And then finally, we also sometimes have these what we call special call funding opportunities. These are generally based around specific Cancer Institute priorities or priorities that have been highlighted or raised by the communities. So some examples of this: in our most recent funding cycle, we released an RFP to address COVID-19 specific community needs. And we looked at how cancer is impacted by COVID, how cancer care has been impacted by COVID, or other characteristics that are impacted or needed to be addressed during the era of COVID. And then other special calls have included implementation of evidence-based walking programs for cancer survivors, as you can see here on the slide, and then a corner store initiative and physical activity for cancer prevention. Next slide, please. So in terms of the funding model, the primary funding model, which is these 3 tiers, these are all 1-year grants, and the 3 funding tiers are designed to support communities regardless of their experience in working around a specific cancer topic or working together as an organization to address these different topics. So they offer a way for communities to take an initial idea and then move it all the way through the funding tiers to develop a more robust or sustainable program. So that being said, though, organizations don't have to start at tier 1. If they've really been already working in an area, they can come in at tier 2, or they could definitely fit into tier 3. And then some do actually walk through all 3 tiers. The tier 1 grants are for up to $10,000. They're really intended to support organizations in identifying their local cancer-related needs, developing a local action plan, and thinking about ways to identify these different priorities. This is where we see a lot of new community groups coming together to work together on something for the first time. The tier 2 grants are for up to $25,000. This is for investing in the development and preliminary testing of small-scale pilot projects to identify a locally addressed need. They do aim to result in preliminary data that can demonstrate a selected approach is feasible and acceptable within a specific community, but we don't anticipate they're going to have rigorous evaluation in terms of a comparison or some sort of a contrast group. And then our largest grants are the tier 3. So these are for up to $50,000 a year. And they're really looking at evaluating the outcomes and the potential impact of a program that's already previously been piloted. And they're either adapting this program or implementing the program in a different setting, and then looking for changes or impact. And then really there is more of an emphasis on these in how they're going to establish a plan for sustainability of a successful program. Next slide, please. A little bit more about the community action model. This is a model that we implemented in 2019 for the first time, really with a goal of trying to support the development of new community organizations to do some grassroots work around specific topics. So as I was saying earlier, this is a 5-step process. It's generally carried out over 2 years. The model was originally developed more than 20 years ago by the San Francisco Department of Public Health, and they've used it really successfully to address tobacco-related health disparities. And so we've worked with that team to adapt their model and then use it. And our first focus has been around the topic of HPV vaccination. So in 2019, we funded our first cohort of CAM grantees. These grantees represented a Hispanic community, a Vietnamese community, a very rural area of the state, and then also a college student organization. So on a university campus, a group of college students that were involved in health promotion. So we've been doing a lot of work around developing a translation of different materials and then seeing the implementation of this approach across these different communities. The grantees, this is a $100,000 award. They get $50,000 for the first year and then have metrics to report out after that first year, and then they receive the second $50,000. They've all completed their first year at this point. They all actually stayed quite active in moving things forward during COVID and are still on schedule to complete their full project in the later this coming year. Next slide. So in terms of our eligibility and application process, it's essentially the same regardless of the grant type in terms of the application process. And there's some very general eligibility requirements that apply across the board. So you can see these here, but there's generally 2 funding cycles per year. Organizations do submit a letter of intent, like some of the other groups that you heard discussed. They do receive technical assistance from our team after the letter of intent stage, and then they can move toward a full proposal. Most folks do. Folks that submit a letter of intent, the vast majority do move into a full proposal. And then the proposals include narrative questions specific to the tier plus the supplement documents. And also these include a budget, project objectives, and evaluation timeline for tier 2 and 3. It's much less rigorous for tier 1. We would anticipate having letters of support and a bibliography as well. Next slide, please. In terms of our review criteria, it's a little different depending on the type of grant that is being offered, but all proposals are reviewed based on merit and not in comparison to one another or based on any other information that may come from outside of what's provided in the proposal. The broad categories that the review panel are reviewing on for each proposal are significance and impact, approach, organization, and team. The budgets aren't scored, but our reviewers are asked to notice any large discrepancies similar to an NIH review. The tier 1 grants, we've kind of gone round and round with this, but we've really landed in a place where they go through an administrative review. It's very challenging for our review panel to try and review a tier 1 together with 2s and 3s. It's like reviewing an RO3 and an RO1 together and looking for comparability. So we do pull the tier 1s out, and those do receive an administrative review. And then in addition to the categories that are mentioned for all the grants, consideration is, we give considerations to things like whether the proposal addresses a unique need or a target or a particular underserved community. And while these are still funded based on merit, there is some more ability to prioritize these proposals to really try and ensure that we're providing funds to areas where we have not been able to fund previously. And then the tier 2 and tier 3 undergo more of a rigorous review. They're reviewed by a larger committee, and we do follow an NIH style approach with each of these sections that I was describing being scored on the 1 to 9 scale. We do hold a reviewer meeting, and then the reviewer panel includes representatives from community organizations, academic scientific experts, and clinicians. And next slide, please. So finally, we do provide technical assistance. I alluded to this a little bit earlier, but the type of technical assistance includes evaluation consults. And here we collaborate with our CTSA's evaluation core, and they actually provide customized individual evaluation support to applicants. Applicants can opt out of this, but most actually do prefer to have an evaluation consult to help think about their evaluation plans for their program and how they implement those. We obviously provide the grantee support. So we provide them support for participating in kickoff webinars and kickoff calls, the evaluation technical assistance, and then training opportunities, such as we still carry out the putting public health evidence into action modules that are a CPCRN product. We host an annual grantee conference for bringing all the grantees together. They absolutely love this. We had a virtual one last year. It was good, not as good, but we're hoping to get back in person in the coming year. And then we provide grantee networking opportunities. And that's all I have.
Awesome. Thank you so much, Dr. Shannon, and all of our panelists. Really helpful information. So we are going to transition now to the Q&A, and thank you, Becky, for taking the slides off so that we can all see each other. So I've been monitoring some of the questions that have come up, and I'm going to ask those in turn. And before we get started, I just wanted to say, and I probably should have said from the beginning, that one of the things that motivated CPCRN offering this Lunch and Learn session was that we recognized throughout the network that so many of us were considering community grant mechanisms, and many of us were in community outreach and engagement roles as well as at our cancer centers. And through some informal conversations, it occurred to quite a few of us that why should we all be doing this on our own and reinventing these wheels on our own, and that it would be helpful to share this information across not only the network, but also to other sites and centers who have community outreach and engagement offices or programs in place. So having said that, I'm going to start with a question to Com that came up in the chat, and it's around the process of grant review. So could you describe how your CAB members are trained to review and what that process looks like?
Yeah, happy to learn from others too. So we basically have an overview. So there's a couple meetings. So the first one is just an overview to the mini grants mechanism. We kind of walk them through the whole applications, of course, the purpose of the mini grants, And then we also go step by step through the evaluation criterion. And as you saw from Dr. Shannon and Hébert, there's lots of different ways that we have, again, for scoring the rubric. So I think it's really helpful to kind of go through what your different criterion are. And for each criterion, say what you're looking for. And so that helps them to kind of go away and do the independent review. And then we are around for questions. And then we have a review period or review round. And then we come back, as others have talked about, and kind of have a group discussion. So there is also training on the staff members. Our research team is involved, but we also want to have community input, and they're the one that's selected to work on HPV. So I think that's very important to kind of appreciate them and what they offer to kind of our relationship with our Prevention Research Center.
Thank you, or I should have said Dr. Escoffery. Let me also pose a related question to the rest of you. Have you encountered any challenges in the community review process? Have any CAB members, those of you who engage them in the review process, struggled at all or asked questions about the process, or has it been sort of smooth sailing from the beginning?
I'm happy to chime in.
Okay.
No, not smooth sailing from the beginning. So our review panel has always been a mix of community members. They're not all on our CAB. They're a wider range than that. Some scientists, some clinicians, some more administrative folks from the Cancer Center. And there's definitely been interactions that take place within the review sessions that have been a little challenging. It's been a lot more challenging with our community members to really discourage them from bringing outside information or knowledge into the review process. So that sometimes has been a little bit of a challenge. It's been sometimes exceedingly challenging to get our academicians to bring their review to the correct, focusing on the correct aspects of the grants that they're looking at and recognizing that they're coming from community organizations, not from other academicians. And then part of why I highlighted this, that we always review on merit, is that with community review, it can be really challenging sometimes, a sense of is there favoritism of who knows whom, and really trying to make sure that there's a clear focus towards merit and feasibility of an application versus we know these folks, they do good work, kind of thing.
I don't perceive that our process has changed. I mean, we've been doing this for a while now, and I think it's fairly consistent. I think that was your question, Stephanie. But Sam and Danielle are both on the call, can feel free to chime in. I think they can feel free to chime in. I don't know if you're muting them or they can actually chime in.
They can jump in.
Yeah. I don't think it's changed over time. I think it's really interesting, Jackie, what you shared with challenges and benefits. And we have had our primary healthcare and other partners involved. And hearing from you all, I'm thinking of ways that maybe we can involve our partners even more during the review process. So this has been really helpful, I think, for us as we move forward. Our liaisons this year with our mini grantees from our CPCRN team are investigators, but our grantees presented for our Community Advisory Council, who have also been very involved. So thinking of ways to involve them even more and understanding these challenges and benefits, I think has been really helpful. But as James said, we haven't really changed the process, only I would say spiced it up to improve it whenever there's been issues. So yeah. Thank you.
I would just add that, I think one, you need a really competent facilitator, right? And I felt like our COE leads did a great job in that regard. Also eliminating any bias. So we had one grant where one of the leaders was involved in some way in the project, so we had to excuse them from the process. So just being true to, reducing bias whenever you can, and then just refocusing people on the purpose, right? Mm-hmm. And I think reassuring them that it's not a one-time, we'll never do this again. There may be other opportunities for funding down the road.
Wonderful. Thank you all for those insights. So we'll go to the next question, and that was contributed by Ronnie Bell and Hope Krebel. So hope you guys got the questions answered that you were looking for. So Cyndi Vinson raises a question about the amounts selected for the grant mechanism. So they range from $3,000 to, we saw with Jackie's, Dr. Shannon's program, multiple tiers up to $50,000 in some cases. So can you guys describe a little bit more about why selecting the lower amounts versus the higher amounts? And I think Dr. Shannon actually describes how your program is structured pretty well in terms of what the different funding amounts for. But what about the rest of you?
Well, the money we're allotting is coming from the grant. It's not coming from other sources. So, we're not in a position to, given the amount of funding, to make grants of $25,000 or $50,000. So just to be really clear about that.
Absolutely. Fair enough.
Yeah, for us, I think in the past, and even this cycle focusing on HPV vaccination, I think we take the whole idea of people being motivated to participate in this as one of it, and also maybe sharing some of that in-kind support. We also, like South Carolina, are funding this from, our own grant mechanism. So if we want to have more people, we do think of, more organizations in this case, and people funded, we do want to think about the amount. I did say in our grant it's budgeted for $3,000, but we will kind of go back before we have the final grant being issued in terms of the application, to talk to our community advisory board and maybe some, potential clinics who may not be applying, but just trying to figure out, what is the range that helps them. So some of them might want to attend the HPV, training offered by CDC to be able to kind of change health systems or provider education. So what are those minimal costs? How can we build on it? And do they have in-kind or direct support, which is why we look for the budget justification, that they're having some organizational capacity and willingness to do some of this as well too. So those are some of our kind of thinkings and also limitations around the funding. So good question.
I would just add that one of the things I've noticed in working with communities is you also need to be really flexible, right? Because sometimes you think there's going to be a cost, and then all of a sudden there's a resource identified,
right,
that's going to be able to cover that cost. And yet you don't want to say, well, it's $3,000 and no more. And then you find out if you had another $500, you could add this on. So I think when we set it based on what the community partner needed to get started, but also wanted to be open to the fact that we might add to that if it, as needed to really leverage the programming.
Yeah, and the flip side of that, which I think you were alluding to, Cyndi, is there are instances where the applicant is able to leverage other resources. And this is all about leverageability. Yeah. When I was, clearly, if you gave us $10,000, well, we're pretty efficient. If you compute the, academic product per unit investment, we're really efficient, but we couldn't get a hell of a lot done with $10,000. Let's face it.
Yeah, so this really speaks to the question that Heather Brandt raised in the chat about other sources of funding beyond CPCRN or Community Outreach and Engagement Office funds. And Dr. Shannon mentioned philanthropy, which is, I think, a totally untapped resource for many of us. And we should all be working with our development teams to really leverage that resource, to use your word, James. But other sources, are there other things that you guys are leveraging beyond philanthropy or COE or CPCRN, the usual sources we talked about?
I would just mention centers, right? So we have other centers that are interested in health promotion. So sometimes we've been able to reach out to other centers for funds.
I did want to make one, a little bit of a caveat on the philanthropy funding also is that, of course, philanthropy often comes with a little bit of strings, and we don't provide any funding to anybody within OHSU or any ties to OHSU. So there is no academic partner on these projects. So the applicants receive technical assistance. All applicants receive the same, but we can't use any of our funding to provide any support to an OHSU investigator. And now it's sort of reached the point where we can't support really any other academic institution investigator either, because we were getting a lot of OSU investigators who were utilizing this as a mechanism for funding, and it was not reaching the community.
That's such an important point, Dr. Shannon. I'm glad you brought it up, because in some cases, grants like these have a requirement that people are working with an academic partner, and in others, like yours and actually the community grants program that we're working on right now, we're trying to exclude actively academic partners so that more money goes into the community, as you said. Really interesting seeing the diversity there. So I'm going to go to the next question, which comes from Perla about technical assistance. So the question that she asked was about whether these community organizations are comfortable selecting strategies, how much technical assistance is required pre-application. So I don't know if any of you want to respond to that. And unfortunately, Dr. Escoffery had to leave us to go teach class, but if anybody wants to weigh in on
Well, one of the things I mentioned in my presentation is there is a lot of variability. So some people, some institutions require a lot of assistance and others, relatively little. But, Sam would probably be the right person to answer that question because he was the front line. I mean, they're instructed to contact Sam, or, Sam's been the project coordinator during this time, whoever the project coordinator happens to be. But for now, it's Sam. So he would have a pretty good sense about what the particulars are regarding that.
Yeah, I can. So in this past time, we did have a lot of variability. One of our community organizations was partnering with other individuals who were previous PhD student in the PRC. So, and the director of the PRC was one of the partners, but not a part of the community organization. So they needed very little technical assistance. They knew what they were doing. But other organizations, sometimes I would get a lot of technical assistance, or reach out for organizations who, even though we said, you can just choose certain strategies, you don't have to choose certain programs, they would be like, I don't know if we have the capacity to implement this whole entire program from start to finish in a year. So just the webinar we then held was very beneficial to the organizations, knowing just identify one strategy that you want to implement or one or two strategies. But we don't want to, we don't want them to think they have to do a whole entire program. But that was probably the main technical assistance, was just clarification, which helps us in that now we can, for the next call for or RFA, we can clarify some things to hopefully clear up those questions earlier.
Terrific, thank you. And I see one more question in the chat, and then we can open it up for maybe one more after that. Emily Billendick asks about the outcomes that you guys selected to measure in your evaluation of the program and how you decided to measure those. Anybody want to address that question?
We were really going for measures of impact. And so we defined that not just in, impact on cancer, but did they build new partnerships? So that's an evaluation metric that we look at. We measure very simple things like, did they reach the number of people they proposed that they were going to reach? So very specific to their programs or their proposed projects. And then also for the tier 3s particularly, we do evaluate on their plans for sustainability and their movement forward in that sustainability plan. But a lot of this was, we spend a lot of time thinking about how do we measure impact of this program. And that's where those metrics came from.
Any others?
Well, I think REACH, we've done surveys to look at behavioral changes and so forth. I mean, one of our programs is a physical activity related program. So, it ranged all the way from, understanding how people were getting information to these behavioral outcomes, which, they hang together, let's say, with cancer-related outcomes, because we know physical activity, for example, is related to a number of cancers etiologically, as well as in terms of survivorship. But did we measure anything? No, we did not measure cancer outcomes. That did not happen.
All right, thank you.
And I would say for our program, very similar. You want to change behavior and do something sustainable. But we also realize that we're trying to increase colorectal cancer screening during COVID when we just took a major hit. So I think the other thing to keep in mind is that our outcomes have all flexed with the new environment this year.
Right.
I think we've all been flexing for sure. Maybe some of you got your workout in during this.
Yeah, that happened.
At a minimum, we hope that you got your lunch in. Well, I think we're close to the top of the hour, so I'm going to turn it back over to Betsy to wrap us up.
Thank you again to all of our panelists. This was such great information. I wish we had time for more questions, but this has been great to especially hear the details about the activities at your sites and how you're managing the processes all the way through from the application to the review process. So I know it's been really informative to me as someone on the beginning end of thinking about doing mini grants. So just a reminder of how to connect with CPCRN. You can find us on the website listed there. And also if you have additional questions that weren't covered today, you can email them directly to Stephanie and Becky, and we will follow up. So anything else, Stephanie, that I forgot there?
No, you covered it all, Betsy. Thank you so much to all four of you for wonderful presentations, and to everybody in the audience. The recording will be made available on the website, and we will be happy to send out a PDF of those slides. You guys are awesome. Really appreciate you spending your day with us today. Thank you.
Thank you.
Thank you.
Bye.
Bye.
Bye.